All right, guys, Dr. Derek McClister here. We're going to be talking about weight-bearing CT scans using evidence-based medicine through the technology, and I'll have some cases to review throughout the presentation. So, what is a weight-bearing CT scan? It sounds exactly like what it is. It's advanced imaging, like a traditional CT scan, um, versus how they do it is a little bit different. So it's usually a cone beam versus a helical scan. And the huge difference in our world is the natural loading position. So we get what is happening when the person is placing weight while standing. So we get true deformity, true impingement, true rotation, all those things that really impact us. Why we usually get weight-bearing x-rays compared to non-weight-bearing x-rays. It's the same thought process of, hey, if you don't have a weight-bearing CT scan, you can get more information with a weight-bearing CT scan. So for me, it's a more accurate diagnosis for certain orthopedic conditions. We'll go through those in a little bit. We get better assessment of joint alignment and deformities under realistic conditions like we just talked about. And I think honestly it shows improved surgical planning due to those more realistic anatomic positioning or those characteristics that we will be talking about. Standard care is now, so we can diagnose arthritis a little bit better. We can diagnose deformities a little bit better. We can diagnose bunions a little bit better. We can diagnose those subtle fractures or syndesmotic injuries, rotational injuries at the distal fibula, Liz Frank type injuries. The pre-surgical and post-surgical assessments can be, hey, we can try to classify, did we get good correction based on what we're doing? And then honestly is you can take, hey, a weight-bearing CT scan, and nowadays technology has, where I'll show this, what we're doing is using 3D printed models to help you look at this in your hands clinically without the skin. You can see what the bones are doing clinically, and I'll show you an example of that. So what does weight-bearing CT scan on foot and orthopedic care mean? It's a focus on patient care. So we're going to get patient-specific information. So PSI, we hear that a lot, usually in deformities and total ankles, but you can do this for anything at this point in time, and I think it is really will be shown to be a really great advancing care. And the nice thing about it is, I didn't talk about it, is that it's a relatively small footprint. You can plug it into a regular wall. It's relatively inexpensive and pays for itself pretty quickly. I think on average you have to do 14 scans a month for it to make you $250,000 or roughly like that throughout a calendar year. So you don't have to be super useful on it. You don't have to get it on every patient. I typically do on most of my patients that I'm doing surgery on. I just got a weight-bearing CT scan on. And again, not every patient. So if I'm just doing hammer toes, I'm probably not going to get a weight-bearing CT scan. But if any deformity, any flatfoot, any questionable bunion, any total ankle, any custom implant, I'm getting a weight-bearing CT scan as long as they can. And then those subtle, Liz Frank, subtle syndesmotic injuries, I think I averaged roughly 250 CT scans over the last 3 years. So I use it quite frequently, and it can make you money if you're a private practice provider. It's more accurate, so you get normal versus abnormal pathology, right versus left legs, just like x-ray. You get multiplane deformity review, you get collapse, you get hindfoot valgus position, and like I said, if you have a 3D printer, you can X-load those and get 3D printed models in real life. I think what really changed my opinion on this study from clinical implications for surgeons for surgery. A study in 2019 of Foot and Ankle International found that weight-bearing CT scan led to changes in surgical planning, roughly 30 to 40% of the cases. It suggests that you will change your surgical opinion and plan based on getting a weight-bearing CT scan versus just a normal one or just standard x-rays. That's almost 50%, and I typically agree with this. I do change my plan quite often, especially on that first ray flatfoot type procedures or bunion procedures that I'm questioning on quite frequently. It's cost effective in the long term. It does cost a little bit more right away, but ultimately, like I said, you can really pay for this relatively quickly, and evidence shows it has less radiation. So all those things, it's not overly expensive. will pay for itself after that first year if you use it correctly and using it on quite a bit of deformities. I haven't got pushback from a lot of insurance companies on using it for deformities, bunions. I always just dictate that I'm using it for arthritis evaluation, stuff like that we normally typically would use. It plugs into a standard wall. You can talk to your orthopedic partners or orthopedic local group and say, hey, if I get this, we can become the weight-bearing center of excellence, and really just kind of push it. And it really fits into most standard rooms, and you can get it from you can get a high-rise one, which will help with the knee and hip. So you can really take advantage of patient-specific instrumentation for knees and hips as well. How I usually use it is pathology that I usually focus on. I usually pes planus, posterior tibial tendonitis, progressing flatfoot deformity, however you want to classify it. I use it really frequently to help me make my surgical plans, and I'll kind of talk about that here in a little bit. I use hallux valgus deformity, or AKA the bunion. I definitely use it a lot of the times if I have question on what's the sesamoids doing, whether there's any arthrosis, if they're a young patient and I'm trying to decide whether a minimally invasive procedure or a lapidus would be the best correction for them long term. I usually use it for foot and ankle injuries, such as the syndesmosis. There's a Liz Frank indication as well. I definitely use it for complex deformities. So if I'm going to print a 3D model, such as a Charcot, such as a cavus foot, such as a pediatric deformity that's just not used to, you can use 3D printed models that really help you do that. And then obviously the total ankle replacements, the total talus replacements, those custom implants that you usually have to get a CT scan on anyways. What better way to do it is then get a weight-bearing CT scan on them. Again, highlighting patient-specific information. So progressive flat foot, it encompasses multiple planes of deformity like we kind of talked about for review. So I look at hindfoot valgus. Then I'll look at subfibular impingement. I'll look at hindfoot pronation at that talonavicular joint. And then I look at medial arch collapse, so that first ray and elevation through it. So I kind of dial in my correction, changing my procedures based on that. Doesn't mean I'm going to change it a ton, but I might add a cotton in it. I might add a lapidus type procedure. I may say, hey, well, we can get away with not doing a subtalar joint fusion if there's not a lot of impingement on a younger patient. So I really do dial in my correction with getting a weight-bearing CT scan. And then what do I look for? You're looking at subtalar joint. So when that hindfoot valgus position, what are we looking for is that subtalar joint. So I look at the orientation. So is the joint oriented in a valgus position? And how do I rotate that to get deformity correction? And then we kind of talked about this. Is there any subfibular impingement? Subfibular impingement can be either calcaneus to fibula or the talus to the calcaneus. It all kind of depends. And then there is arthritis evaluation. There is some facet evaluation that you can look at, but I'm not super tied into that. Midfoot, I'm looking at the collapse and abduction. So I'm looking through, hey, how much is the talonavicular joint collapsing and allowing rotation that allows the abduction of the foot and then the collapse of that medial column. So those are the things that I really dive into when I'm looking at it. Cesar de Caesar is the guy that has led the pioneer of weight-bearing CT scans. So you'll see his name classically on all these papers here. Basically, flexible flat foot deformity. They wanted to determine whether a weight-bearing CT scan provides more accurate assessment of adult acquired flat foot than a regular non-weight-bearing CT scan. Basically, it's a prospective study, so they took two different groups and they studied them. And they had 20 patients, so not a ton. They each got a weight-bearing CT scan and a non-weight-bearing CT scan. They performed certain measurements to assess the deformity, and they really wanted to see if it was reliable. What they found was that 18 out of 19 measurements showed significant differences between the weight-bearing one and the non-weight-bearing one. That's a pretty significant number. And then they concluded that the weight-bearing CT scan is superior to the non-weight-bearing CT scan in evaluating severe flexible flat foot deformity. This supports integration of weight-bearing imaging into the standard diagnosis of a flexible flat foot. We always get weight-bearing x-rays. Why wouldn't we get a weight-bearing CT scan if it has it available? Anywhere I'm going to be practicing, I'm going to be highlighting the financials of it and the use of it and the viability long-term of this. Again, talking about subfibular impingement, I use it all the time for this. Study, I think 2019, they evaluated bony subfibular impingement or talocalcaneal impingement with flatfoot deformity and posterior tibial tendonitis. It's a retrospective comparative study. They diagnosed patients with flatfoot deformity and tendonitis and underwent weight-bearing CT scans. And then they analyzed measurements of it. I'm not going to go into the significant differences of these different images. You have to read the paper, but basically they measured certain criteria and they found that it was useful. And then they had a control group, which was normal, healthy patients to really have like a measurement of normal. So they did compare it to a normal group. This is an example of what subfibular impingement would look like. And as you can really see, you can actually see it in both areas. This is calcaneus to fibula, and you can see talus to calcaneus. So first image, talus to calcaneus, getting that lateral process impingement, and then the B image is that calcaneus to fibula. And basically, they found that 35% of patients had subfibular impingement, and they found that talocalcaneal impingement was in about 38% of patients with flatfoot deformity. They found the sinus tarsi volume decreased in flatfoot, which goes correlating, which, if about 40% of the patients are getting impingement, that you are going to have some sort of decrease in volume. They basically, in healthy volunteers, they did not really see a huge decrease in volumes, significant differences, even though it did decrease if you did a weight-bearing CT scan just because of the loading effect. What they did, they concluded that bony subfibular impingement or just impingement in general is prevalent, so 40% roughly in these patients, and it's a valuable tool in assessing these impingements. We might miss these unless you're really tuned into this on your exam, so I really think you have to diagnose this and not just think, it's peroneal tendon pathology. It might be, hey, they're getting impingement at the subtalar joint. They might have mild arthritis at the subtalar joint. They might just be getting impingement because of how bad their valgus deformity is, and I really enjoy this. I also will go back and highlight this second image. You can see their orientation, that valgus orientation of the calcaneus compared to the weight-bearing surface of the tibia. It's totally in valgus, which means that the foot is really collapsing. They're getting a lot of hindfoot pronation on that B image. And then here is another paper on that facet, and then subluxation of the foot, middle facet, and then they did what's called a foot and ankle offset measurement. I'm not going to say this is my favorite paper because I think it's really more time consuming in my opinion to do, but you can still get evaluation of the facet by looking at a weight-bearing CT scan, and it might show you that, hey, if the facet is getting worse over time or it's subluxing more, is that you might need a more aggressive procedure to correct the flat foot. 2022, basically they wanted to correlate middle facet subluxation and foot and ankle offset in progressive flat foot deformity, and they wanted to say, hey, can it serve as a reliable marker for flat foot deformity severity? Retrospective design, they diagnosed patients with progressive flat foot deformity, and they got weight-bearing CT scans on them. They basically measured middle facet subluxation, and then they measured this foot and ankle offset number, which is basically will either be positive or negative if it's in a valgus or varus orientation, which again helps you dial in whether you can correct it enough or not correct it enough if you get a pre-op versus post-op numbers. Here's a weight-bearing CT scan. They're looking again at that middle facet and seeing if it's subluxation. And then they took basically the first metatarsal, fifth metatarsal, and then talus. That's your and then you can get the foot and ankle offset, calcaneus, and you get the foot and ankle offset number because that'll help you tell you if you're in a varus valgus position. And what they found was a significant positive correlation between middle set subluxation and foot and ankle offset. So basically, if you had greater subluxation, it is more of a bigger deformity, which makes sense. If you're subluxating at a joint, that likely means it's a worse deformity, whether it's at the first MPJ, whether it's at the talonavicular joint, whether it's at the middle facet. And that's where it really makes sense. But are you going to spend a bunch of time doing all these measurements? Probably not a huge amount, but you can help pre-op versus post-op really dive into it if you got good deformity correction. I fuse a lot of subtalar joints for flatfoot, so I don't secondarily go back and look at it. They concluded that middle facet subluxation was a reliable marker for assessing progressive flatfoot deformity progression, and middle facet subluxation is a reliable indicator of progressive flatfoot deformity severity. So basically, if it gets worse and it's subluxing worse, it's a worse deformity. You may have to do more of a robust correction. That's what it correlates to me. And again, I usually fuse a lot of subtalar joints, so I don't really sit there and stress about it too much for this flatfoot deformity. But it's a good paper. I know my colleague uses this and says, hey, I might fuse a subtalar joint if the middle facet is subluxed a lot. All right, talking about the flatfoot continuing, and then talking about this foot and ankle offset. Another study that goes right along with the study we just talked about was the foot and ankle offset. These guys wanted to measure if it was can be used to help correct your deformity, to say, did you do a good job correcting it before surgery and after surgery? Again, Caesar to Caesar as part of this. He just is a workhorse in the weight-bearing CT scan world. So they wanted to assess the utility of the foot and ankle offset, and they did it for flat foot deformity, stage 2. They followed the patient, so they had before and after, so they did a prospective comparison study. They did weight-bearing CT scans preoperatively and postoperatively. They followed them. The foot and ankle offset is the first metatarsal, fifth metatarsal, and calcaneus. I think earlier I had to correct myself. It's not the talus, it's the calcaneus, and that's exactly what we look at with a weight-bearing exam, non-weight-bearing exam. We look at the first metatarsal, fifth metatarsal, and the calcaneus, valgus orientation, forefoot varus. Hey, I got to correct the forefoot varus, so I need to get that first metatarsal down or that first ray down, doing a cotton, lapidus procedure, whatever you kind of prefer. And that's how I always describe it. I describe a tripod, and that is the tripod of the foot. That's kind of what it would look like in the computer system. Basics of this is closer to 0 is more neutral. Positive, the higher positive number usually is valgus. The more negative number, so -4, is more of a varus position. So the more you get to a neutral position is closer to 0 on both ends. They did patient-reported outcomes. Again, they followed them for a little while. They basically found that the mean postoperative and preoperative was improved from 9% to about 1.3%. Showed they got better outcomes when it was closer to that, so they had significant improvements. And then they kind of found that, I thought this was interesting, that when they did a spring ligament reconstruction for a stage 2 was notably better correction in the foot and ankle offset. So it helps support that medial column, that medial hindfoot pronation a little bit better, which again would allow less valgus or pronation through the hindfoot, which I think we all kind of make sense. Again, I'm not a huge spring ligament repair guy, but I will do some augmentation to it if I'm doing an FDL tendon transfer, because I'm going to be there. But if I'm going to do a subtalar joint fusion, I don't really stress about doing a whole bunch of medial column soft tissue work if I'm fusing the subtalar joint. And they concluded that foot and ankle offset derived from the weight-bearing CT scan is a valuable tool for quantifying deformity correction. And then obviously you can assess whether you did a good job if you pre and post operatively. And then alternatively, they found that the spring ligament, if you did that with a stage 2 flat foot, that you might get better correction using this technique and measurement tool. Again, all about, hey, did you do a good job getting the foot back underneath the leg and getting a good correction, balanced forefoot to hindfoot? And I think this is a good study showing weight-bearing CT scan can be used preoperatively to help you determine whether you should, what type of procedures you should use, and they can help postoperatively assess one healing, so fusion, and then 2, your alignment and correction. I got a case, hindfoot pain guy, 68-year-old male at the time that he came in. He's had chronic deformities, both right and left feet. His right foot had surgery on it a long time ago, born with pain. A vague history of surgery, like I talked about when he was young. He's had poor function, poor pain. He can't fit into shoes, insoles. He's just really struggled. Bracing really hurts him when he puts it in. Large deformity. Otherwise, he's healthy. He had a skew foot type, semi-reducible hindfoot, so I could get him into a better position through his hindfoot, but you can't really assess a ton of the midfoot. It was more rigid than anything, and I didn't really focus that because most of his pain was hindfoot pain more than midfoot pain. This is what his x-rays look like. This is the left. I did the left first, and then I did his right later on, about a year later. But you can see how bad a severe subluxation or hindfoot pronation through that. You can see that twisting of the midfoot where that skew foot kind of looks like. That's his hindfoot. You can see, in my opinion, I'm now paying attention to this on x-rays, he's likely getting subfibular impingement just based on that x-ray. He's got this windswept foot. Weight-bearing CT scan, there's that subfibular impingement, shows it really clearly there. You get a great look at it. If you looked, this would be the medial facet showing subluxation, so he has a severe deformity. We already knew that based on those x-rays. And then this is a really good view of that medial facet subluxation. This is the medial column. You can see how he is basically collapsed maximally at the navicular cuneiform joint, and he's elevated through that first tarsal-metatarsal joint. He's got mild arthritis of his big toe joint as well. So you get robust information through a weight-bearing CT scan. So I did a surgery on this guy. I usually keep it very standard when they have this big a deformity. I did an EGR, so endoscopic gastroc. I did a triple and a cotton on this gentleman. That is what the correction looks like. I'm an Arthrex user. So I use a lot of Arthrex product. I use Allocine Pure for bone graft augmentation. I always use a bone stimulator when I'm fusing the hindfoot or ankle joint. But that's the lateral, so you can see severe correction. I got his foot really great correction out of this guy, and he's very happy. We ultimately, I think 9 months later, we did his right foot as well, and he's been overly just thrilled. He said his quality of life is significantly improved. I didn't get a weight-bearing CT scan on this to assess my correction because he was doing so well. Why would you waste the patient's money? But if we were doing studies on this, I think it would be a great study to do. That's the hindfoot alignment. So again, trying to get everything neutral as best we possibly can. I get hindfoot alignment preoperatively and postoperatively. As you can see how with his deformity, his calcaneus changed shape over time. It tried to get himself to a neutral position. I've realized on these patients that have had a severe deformity for a really long time, if you overcorrect to try to get the talonavicular joint perfect on x-rays, you might put them in a little bit more valgus or varus position than you would want. And so I've learned a lot through my own work, but that's something now I routinely get is this hindfoot alignment views preoperatively and postoperatively. Takeaways. Really, weight-bearing CT scan helps you assess in multiple planes. I think that last study, or the last case really showed that. You got to see subfibular impingement. You got to see the middle facet. You got to see if there was any arthrosis. You got to see how collapse of that medial column was, how it's going through the navicular cuneiform as well as the first tarsal-metatarsal joint. I didn't do a lapidus for him. I didn't do a first MGF fusion because I've also found that if you make the medial column really stiff and you also make the hindfoot stiff, is that they don't compensate well and they don't have give. So you want to have them have some give somewhere, but you also want to make them in a good position so the deformity doesn't go to the ankle, because there is some questions on that. What do I think for this is that same thing that I just talked about, implications for surgery. So should you add a cheater cotton? So a lot of people maybe aren't aggressive enough on this medial column work, and they kind of just leave it alone and say, that's good enough, I got the hindfoot better. Well, that's where I think if you still have a forefoot varus, and they're going to collapse, and if you have a forefoot varus and they collapse, it's only going to go in two places. One, they're going to get issues with the medial column, or two, it's going to go to the hindfoot and it's going to go to the ankle because they're still collapsing somewhere. And then you can either get a cheater cotton, you can do a lappy cotton, which has some good stuff, and then you obviously just want to have the best hindfoot position. this study, Conti, they basically said that for stage 2 deformity, you want to be close to a varus position. You don't want to overcorrect it to be in varus, but they found that you want to be really neutral. You don't want to still have valgus position, otherwise they don't get good correction long term. And Caesar to Caesar, another lappy cotton type study where they did a lapidus and a cotton procedure in one. So lots of different studies, lots of different things that you can look at. I really have a passion for bunions and weight-bearing CT scans. Obviously, you'll see me in research. I've kind of already did a presentation on this, but I use it a lot for bunion deformity and evaluation. The first metatarsal phalange joint is a unique joint. It's got lots of different things surrounding it, whether it be the metatarsal, whether it be the phalanges, whether it be the sesamoids, whether it be the soft tissues. We just think, oh, it's a bunion and it's a bump because that's what patients come in for, but it's really a complex deformity. So again, first metatarsal, proximal phalanx, sesamoid bones, and then the ligamentous and tendinous complex. I also view a whole foot structure opinion. That's where I probably may be different than some colleagues. If my patient's 18 years old and they have a flatter foot and a bunion, I have low threshold to do a gastroc, low threshold to do a calcaneal osteotomy and a lapidus procedure on those. If they're 55 and they have a bunion and a flatter foot, they've lived that long without really having lots of pain, I'm likely either just going to give them first MGA fusion if they have any arthritic concerns, and I'll show that here in an example, or I'm just going to do a lapidus on them or something like a minimally invasive surgery depending on how they're feeling about it. So I also use weight-bearing CT scans to help look at the foot structure, to help my younger patients and older patients understand what is going on with the foot and the mechanics, maybe why they did or why they did not develop arthritis. 3D algorithm, Dr. Dayton and all the individuals that have done a lot of work on the triplanar correction really gave a good paper and good classification for this. I'm not going to go into detail, but basically know that the bunions are 3D deformities, not just 2D, and like how we used to think about it in the old day or we got taught in school. Weight-bearing CT scans on bunion deformities. What do I look for? I look for metatarsal pronation. I look at the sesamoid bones, and then I look at the foot structure. This Kim et al. Study back in 2015 really changed my mind on this. I'm not going to belabor the point on this, but they used they wanted to know what happens to the first metatarsal and sesamoids on a non-weight-bearing CT scan or a semi-weight-bearing CT scans. They didn't have a lot of patients, but they did patients with a bunion deformity and without. And then they did a comparison on that, those individuals, retrospective review, and basically, this is what they found, is that there's 4 classifications. 1 is a normal joint. 2 is a non-normal joint where the sesamoids are subluxing, but there's no pronation of the metatarsal. 3 is where there's pronation of the metatarsal, so it's pronating, and then there's no subluxation of the sesamoids. And then 4 is where there's pronation and sesamoid subluxation. Number 3 is where that's pseudo-subluxation, is where you look on that AP view and it looks like the sesamoids are subluxed, but it's actually just metatarsal pronation, so it kind of can confuse us. And this is really what made me really like weight-bearing CT scans and the thought of using it on bunions. So this study really changed my mind. What they found was that the first metatarsal pronated a whole heck of a lot. So they said around 80% of the patients or 90% of the patients. They found that about 72% of patients had some sort of subluxation. And then if that all those numbers are true, that means that about 26%, roughly 28%, depending on how you look at the stats, is that there's some pronation without subluxation. So a quarter of the patients in your practice will look like they have some issues with the sesamoid, but it's actually a first metatarsal pronation instead. They basically said using a CT scan under simulated weight-bearing surfaces will give you better diagnostic accuracy. And then they said if you know that the first metatarsal is pronating versus subluxation of the sesamoids or just subluxation of the sesamoids, you might need to do a lateral release. You might need to do a supination of the first metatarsal to get the correction. So it helps you in surgical planning. These guys followed up using a simulated weight-bearing surface, and I'll show you this. And they wanted to find the weight-bearing parameters. This is again simulated. This is not exactly a weight-bearing CT scan. Obviously, you guys can see that. And what they found was that when you simulated weight bearing, it changed the foot mechanics. I'm not going to highlight this a ton, but the first ray changed. That's what I want to highlight, is that something changed when you load the foot in the first ray, and which is, I think we all just looked at the last flatfoot study or flatfoot patient that he gave. You could really see what's going on in that first ray really well. And they concluded that the loading of the foot causes 3D displacement at multiple levels of the joint, and the first ray may play a role in hallux valgus. I think we have all kind of concluded that, but this study really did show that. This is our original research from our institution and myself, or my former institution. It was published in 2026. It's a retrospective review. We got X-rays and a weight-bearing CT scan preoperatively. We didn't get it postoperatively unless there was a complication, so we don't have a ton of data on that. But what I was looking for is, hey, if I had a patient that I questioned what type of bunion procedure I should do on, let's get a weight-bearing CT scan and find out what's happening at that joint. My brain tells me that I need to do what's best for my patients, and maybe I should have a better evaluation of that. What we found was a little bit similar and also a little bit different from the non-weight-bearing CT scan or the simulated one that Kim et al. We found that 60% of patients had pronation and subluxation. We found that 80% of patients had true sesamoid subluxation. So very similar to their 72%, but we had a little bit more. We had way less pseudo subluxation. So we only had about 9% of that. The biggest key that I found in this, and I found that I thought was most interesting on these patients that I had questions on, and again, this may be a little bit biased because they were patients that I just questioned on, but I do a lot of big toe joint fusions, and so I don't always get CT scans on every bunion if I'm going to fuse the big toe joint, is that 58% of patients had some form of arthritic degeneration. So there were some cystic changes, there was some joint space narrowing in about 60% of our bunions. I think that's a significant number. And then about 50% of them either didn't have a crista, it was abnormal, so flattened, or something was not typically what we would normally think of a crista trying to hold these two sesamoids in it. Whether that was age-related, whether that was not age-related, we need to do some more research into that. But in general, about 50% of patients either had some degeneration or abnormal crista, which I think go hand in hand. Sesamoid subluxation, they found that basically, or we found, that they had more meaningful or bigger deformities. So if you had more subluxation, they had a larger bunion. Concluded that weight-bearing CT scan is more accurate evaluating than regular x-rays. High percentage of patients had subluxation noted, so a lot of sesamoid subluxation, and then I had a relatively high percentage of arthritic changes or abnormal crista, and I'll show you an example of a case here in a little bit, what I mean by that here in just a little bit. Overall, here's a pretty good study using weight-bearing CT scan after doing a Lapidus type procedure. 2019 level 3 study, Lapidus done for hallux valgus. They did pre-op and post-op radiographs and a weight-bearing CT scan done. They concluded that weight-bearing CT scan gave more detailed forefoot alignment. They noticed that the sesamoids were reduced after doing a Lapidus procedure that led to an increased height of a second metatarsal. This is kind of a diagram what they showed after doing a Lapidus. If you correct it correctly, you can get a better pronation correction, you get better or position, you get better sesamoid position, and that overall leads to an elevation of the second ray, which likely means that maybe we don't need to do as many while osteotomies as we once thought if we're getting good correction. Here's another good one on weight-bearing CT scan and effective Lapidus on pronation. Conti et al., Foot and Ankle 2020, level 4 case series. They found basically the modified Lapidus procedure was an effective tool. They used lots of different ways to measure things. He has a lot of research on that first ray and metatarsal pronation. But basically what they found was that there was a change in pronation of the first ray. They, however, did not find that reduction of the sesamoids was associated with that pronation of the first ray. So independent. I think that goes hand in hand with our study, Kim et al. Studies, that just because you can get the pronation corrected, doesn't mean the sesamoids will fit where they're supposed to be. Or, in my opinion, pay attention to that sesamoid subluxation. And then they basically said correction of the sesamoid subluxation did correlate with the correction of the IM angle. So if you got a better IM angle correction, you likely tighten the soft tissues, which gave you a little bit of better correction of the IM angle. All right, guys, here's just another evidence dump on weight-bearing CT scan and bunion deformity. I used this to help kind of write our paper. Conti et al. Found correlation of different methods of measuring pronation of first metatarsal on weight-bearing CT scans. Basically, they found that if you use different methods, you're going to get different measurements, and based on those techniques used. So they used alpha angle, which is the most commonly used way to find if there's pronation, and then they used different other methods, and they said, hey, you might get different findings if you use different methods, which is, I think, is reasonable to say, hey, if you're not using it consistently, or if someone else is not using it consistently, or they're doing it a different way, you might get different findings. The next study is repeatability of weight-bearing CT scans for measurement of first metatarsal alignment and rotation. These guys found that measurements of first metatarsal alignment and rotation are reliable between assessors and repeatable. They use metatarsal pronation angle and the alpha angle. They found both of them correlated well. I think the pronation angle is relatively simple to consider, is that if you have the parallelism of the metatarsal bottom aspect of that, the 2 points of the distal aspect of the metatarsal parallel with the ground, it's likely not pronated. If they're increased angle, it is likely pronation. And then alpha angle is one that's been very commonly described. The role of weight-bearing CT scans in hallux valgus deformity. They said weight-bearing remains a useful tool in assessing metatarsal pronation and guiding if or corrected alignment or rotation alignment is needed, such as Lapidus procedure or your minimally invasive procedures that you may use. They use the alpha angle. I use these guys for our sesamoid position to help us guide that. So this is a commonly seen one. We use this very consistently on how to measure it, and we really liked it. The assessment of first metatarsal pronation in the normal adult using weight-bearing CT scans, I also thought this was very helpful. Does a person that not have a bunion or a normal foot have pronation? And they found exactly that, as that metatarsal rotation is a variable, is variable in normal feet. There can have normal metatarsal pronation is defined less than 16. Normal alpha angle is defined in less than 18. Both metatarsal pronation angle and alpha angle are reproducible methods for assessing rotation. These guys are the top paper as well, so you'll see a very similar methods of finding pronation available for those. Overall, guys, I talked about a paper describing sesamoid axials versus weight-bearing CT scans. This is the study, Seabeard et al. 2023 type paper. They basically compared weight-bearing CT scans versus sesamoid axials to see if they were very close or accurate together. They did radiographic findings. They basically found that both were accurate ways of measuring metatarsal pronation and sesamoid position on that compared to weight-bearing x-rays. And so basically they said that, hey, you can get good information from a sesamoid axial view. My take on this, and why I think our paper really helped us, is that we know x-rays fool us sometimes, and if the x-ray tech positions the foot just a little bit off, if there's not a clear image, do you get that full detail? So do you get the arthritic findings? Do you get the cystic changes? Do you get to actually see if there is a crista? So it would be nice to say, hey, let's correlate now our study with this type of study and see if we find the same things. But basically they concluded that metatarsal pronation was able to be seen on weight-bearing radiographs and CT scan, not significantly different. Both methods can be reliable to use first metatarsal pronation and get similar values. Again, I don't think that it's quite as crystal clear describing this paper, because you don't get arthritic changes. You do not find out if there's crista present, all those things that I said and highlighted on our weight-bearing CT scan that I thought were very valuable to find out from doing our study. So 16-year-old bunion pain comes in. She's had inside shoe pain for the last 2 years. Nothing has really made it better. benign exam, health exam overall, mild pes planus, pronation, collapse, mild to moderate bunion. It's reducible. The joint moves fairly well. We got right foot imaging. What does that look like? That's her foot. So nothing too crazy. I wasn't super impressed, but clinically she had a little bit more flatter foot than what the x-rays showed. Again, we got a weight-bearing CT scan. That weight-bearing CT scan to me showed a significantly more hindfoot pronation than the x-ray itself showed. And then you can really see the elevation through that medial column. So again, to me, on a young patient, 16 years old, she has collapse through a hindfoot and a bunion. I'm going to try to do a more well-rounded procedure. So I'm going to try to correct all this, hopefully long-term, so that medial column doesn't become a problem long-term, where I've seen a lot of patients that have had flat feet and they get elevation through their first ray, and they basically either get posterior tibial tendonitis, they get first tarsometatarsal joint arthritis, or they get arthritis at their big toe joint. And that's what I've seen in my practice, and I've tried to, if I correct a younger person's foot, try to hit all of those points at one time and early on, so I maybe hopefully will give them better correction long term. This is what the sesamoids look like and first metatarsal look like. You can see that there's really no major crista there. It's really non-existent in my opinion. The sesamoids aren't subluxating. She is rotating, so she does have first metatarsal pronation. So what this means to me, I probably don't need to do a lateral release. And I probably, in my head, based on the weight-bearing CT scan, should do a calcaneal osteotomy, so like an Evans, which will help the first ray as well. And then I do also a first tarsometatarsal joint to depronate it and help her, hopefully, foot get rid of any elevatus through that first tarsometatarsal joint and give robust correction. And that's what we did. We did an EGR, Evans, and a first tarsometatarsal joint fusion or Lapidus type procedure. This is my procedure. I guess I did an Aiken with it to add into it, so I should have put that in there. But I just try to get the medial column in one plane or one corrected plane. So at the end of the case, if the great toe is drifting a little bit, based on our previous bunion talk, that if there's a little bit of hallux valgus angle, I'll try to do an Aiken to get that first ray in one straight position. That's what the hindfoot looks like. Based on the weight-bearing x-rays and the intraoperative films, you really can't tell that I got a bunch of correction. The CT scan would have showed this, but the lateral definitely shows that I elevated the calcaneal inclination. Patient's doing well. She's now a year out. I wish I would have taken some post-operative films. She's doing great. She's very happy that we did the procedure. No major complications. Another case, bunion, case 3, bunion pain, 59-year-old female. Bunion, it's gotten progressively worse. She's tired of it. She definitely has pes planus on exam. She has mild concerns with OA for range of motion and first metatarsal joint reducibility. She doesn't really want a big toe joint fusion, but I said, hey, we're going to get more information. She has a mild to moderate bunion. X-rays, that's what it looks like. So significant hindfoot pronation in my opinion. Mild bunion, doesn't look too bad. X-rays don't really show big arthritic issues, but something was goofy on the physical exam with that first metatarsal phalangeal joint complex. You can see on that lateral image how much she's collapsing through that navicular and cuneiform joint first ray medial column. So got a weight-bearing CT scan to help tell my patients what she should do. This is an example where something didn't feel right with my exam at the reducibility, the gliding of the sesamoids. So physical exam keyed me in. Degenerization at that crista. So she kind of had a crista, but it's got cystic changes because it's arthritis. It's bone on bone, and then you can see that lateral spurring. So to me, this is a no-brainer. You got arthritis. You have a flat foot. You're 59 years old. Let's just do one procedure, solve all of the issues, and likely not have to do anything else to your foot structure. Lateral exam shows elevation through that first tarsal metatarsal joint, shows bone-on-bone arthritis of that sesamoid first metatarsal complex, a little bit of arthritis of the first metatarsal phalangeal joint itself, but overall that correlates with that x-ray fairly well, that the actual joint itself doesn't look bad, but it's actually based on physical exam, that sesamoid complex that looked worse. So I did a first imageal fusion. She had a Taylor's bunion. She ultimately, the day of surgery, wanted me to fix that. I threw a screw across it. Nowadays, I'm just letting it float. But I did a big toe joint fusion on that patient. Super happy. She wasn't having lots of hammer toe pain, so we didn't correct any hammer toe. If you look right here, I usually do a calc bone graft harvest when I'm doing a big toe joint fusion, and I use the OsteoAuger from Arthrex. Again, I'm an Arthrex user. Not that you guys have to use Arthrex products, but that's that's the company I use when I'm doing this type of stuff. Case number 4, bunion gone wrong. I don't think there's anything wrong with this, but I think maybe this shows you an example of how well or how much a big toe joint on a young patient is valuable to get a weight-bearing CT scan on these patients to make good decisions. So a 16-year-old female, she had chronic pain. She had a bunion procedure, was done by my previous partner. He was just like, I don't know what's going on with her. I think I've got good correction. Derek, will you just take a look at it? Chronic pain after, it's stiff. It's not getting better. X-rays look good. And again, gave me a second opinion. So physical exam, first metatarsal joint alignment looked like it was good on exam. It looks like the toe is straight. It looks like there is zero bunion. However, it's very stiff. There's minimal dorsiflexion, plantar flexion, and it feels stiff. So arthrofibrosis, in my opinion. And then she's hypersensitive. Again, patients sometimes are just difficult to examine, but something was going on in the joint that didn't make sense. Imaging, x-rays, and weight-bearing CT scan were done. So here's the post-operative and pre-operative exam. Again, I would say that my partner did a good job. I think it looks great. I think that, all in all, that he had good correction. I maybe would have added an Aiken in my hands, just saying that I would have wanted it maybe just to be a little bit straighter based on a young patient, and I'm going to get that hallux valgus as best as possible. But that's neither here or there in my opinion. Weight-bearing CT scan though. Didn't get it preoperatively. This is what it looks like postoperatively. As you can see, there's absolutely zero crista. There's no crista on this patient at all. She's 16 years old, so she has no crista to hold things where they need to be. So I think it just got super stiff after everything got realigned, everything tightened up, and then the joint didn't move well because there's no normal anatomy for this patient. And this really shows to me why it's important to know that. Here's the weight-bearing CT scan on the lateral, maybe a hair elevated at that first tarsal metatarsal joint, but in my opinion, it looked really good. There's nothing that I would say that the provider or anything that was wrong with the choice. I would have done a Lapidus too. I maybe would have added an Aiken, but she doesn't have a crista. So if you go into this surgery telling the patient that their big toe joint is already abnormal, that we're going to try to make it good and as best as possible, but when you already tell them that there's something abnormal with their joint, their outcomes might be better, their perception of their surgery might be better, and then you really educate them that range of motion is super important right away after surgery, because we want those soft tissues to kind of correct themselves instead of maybe being, hey, we're worried about your hypersensitivity, don't do anything about it. So my next steps for the patient, I had them get an injection done by radiology. I told them that they probably should have an evaluation just because of how sensitive they were. And then also ultimately I said that we could take her to the OR, break up the scar tissue by doing aggressive arthrofibrosis. The knee guys do that a lot after knee scopes if they get arthrofibrosis. So we could maybe go scope her out or just break up the joint and the scar tissue by manipulation, so we can really be aggressive with it and then get her to physical therapy to help after that. And then I said if none of that works, we could always consider doing a big toe joint fusion. Now the youngest patient I've done a big toe joint fusion on was about a 21-year-old after she had a failed bunion when she was 16 and it went to be really arthritic. So I've done that in the past. It's not something that I usually tell my patients I'm super, super adamant to do. But this is an example of me knowing that I love weight-bearing CT scans. I think my study proved that with our group, that there's something sometimes abnormal about patients, and we would never know that just based on that. There is a good study showing that CT scans and sesamoid axial views also help as well. So if you can't get a weight-bearing CT scan, maybe you need to get a sesamoid axial view for all your bunions. I'm just adamant about getting weight-bearing CT scans because I can get so much more information. But this highlights that a lot, I think. Takeaways. Hallux valgus is a complex deformity. Consider subluxation of the sesamoid. So Kim EDL found about 70%. We found about 80%. So you might need to consider a lateral release. Always consider those axial views like I was just talking about. Please consider arthritis at the sesamoids, and then please consider the whole foot. Again, surgical implications. Do you do a lateral release? Do you need to do a whole foot correction? I think that's up to you and your patients and making those decisions together. There's some good studies on the Lapidus procedure. There's some good studies on pronation of the first ray, and there's a good study on elevatus with hallux valgus and flexible flatfoot. So really just there's studies out there that prove why I like getting a weight-bearing CT scan on bunions and evaluations of them. So don't be afraid to do it or get pushback from your institution or say I'm a bunion procedure person, but if I get weight-bearing CT scans, I might make extra money from a financial standpoint, or your institution might make extra money, but it ultimately serves the patient. It's not serving you. You might indirectly get benefits from it, but ultimately we're trying to serve patients, so it's the best of both worlds, in my opinion. Subtle foot and ankle injuries. Ankle syndesmosis is usually the one I get this weight-bearing CT scans on. It's not just a sprain. The syndesmosis is a complex joint. It encompasses the tibia, fibula, talus, and the ligamentous complexes. What are we really looking for these subtle injuries? I'm looking at the insuria, the rotation, and the area. Those are the three things that I have found in my practice that really make a difference. Is the fibula sitting where it's supposed to be? Is it rotated differently? And then comparison right versus left, is there a different area or volume? So good studies on this. Evaluation of the syndesmosis, reduction on CT scan. Basically, they wanted to test whether a CT scan using weight-bearing methods would be better after surgical fixation. Retrospective case study. All patients went under weight-bearing CT scans about 3 years postoperatively after a unilateral syndesmotic injury that was fixed. They took CT scan measurements of about 1 centimeter from the tibial plafond. They used 9 methods to measure it. And then they had different people evaluating the CT scans. This is kind of the studies that they were looking at. They looked at rotation, they looked at syndesmotic area, a bunch of different things to find out if it was correct or not. They found the most reliable result from this was the syndesmotic area, which is, again, why I use that. The second most reliable was the fibular rotation, which is why I do that. And then the least reliable was a subjective side-to-side comparison. So if you didn't have it perfectly aligned, that you can't usually use that side-to-side comparison for that. So again, I look at insuria, I looked at the rotation, and I looked at the syndesmotic area. Those are my 3 highlighted points. I think this study proves that fairly well. And basically, they said that weight-bearing CT scans can accurately help you diagnose syndesmotic indications and support integrating into weight-bearing CT scan practice. Syndesmosis our area is the most reliable. The range of normal versus abnormal, another study using weight-bearing CT scans, 2019. They did normal anatomy versus abnormal anatomy, and they had unilateral syndesmotic instability. So not very big, but it's a comparison study. They did have a control group and a non-control group. Imaging, they all had bilateral weight-bearing CT scans of right and left. They used 7 different measurements. They all used that 1 centimeter above the tibial plafond, and they assessed that by 2 different providers. And again, they found that syndesmotic area was the most significant uninjured versus the injured side. They did find some differences between anterior, medial, and posterior differences. In healthy controls, there was no differences in those between right and left, which validates the previous study. This one validates that those syndesmotic area is very, very important. It was basically effective weight-bearing CT scans under physiological load can diagnose these injuries very well. Syndesmotic area is the most effective and sensitive measurement. It increases the diagnostic value of weight-bearing CT scans and subtle injuries, and it identifies as the most syndesmotic area is the most reliable once again, and it validates using this as contralateral as an internal control. So, which is what I do in my practice. I get right and left weight-bearing CT scans. I'll get right and left weight-bearing X-rays just to satisfy insurance companies. But again, I use this quite frequently. I have a case study to kind of show that. Another good study on weight-bearing CT scans and syndesmotic injuries. Basically, cone beam weight-bearing CT scan to detect syndesmotic injuries on acute. They also confirmed this arthroscopically, which is a little bit differently about this, and then they compared it to a non-weight-bearing CT scan. Again, very good study in my opinion. They had 39 patients. And they used weight-bearing CT scan, non-weight-bearing CT scan. They also did an arthroscopy on these ones. And here's kind of what they looked at. Again, showing different examples of how people are doing it. This is the syndesmotic area, the bottom images, and I really like that. Outcomes. They found that differences in syndesmotic areas versus the injured versus uninjured side, which is what the two previous patients or the one previous study showed, and then this one highlights that. And then they found differences between weight-bearing CT scans versus non-weight-bearing CT scans. So non-weight-bearing CT scans are not as superior to diagnosing these injuries or these subtle injuries as we might think. It helps if they're really unstable, which we would know and see, or if there's rotational injuries, but loading the foot is so important on diagnosing subtle injuries. Weight-bearing CT scan showed a significant increase in the syndesmotic area and unstable ankle injuries versus unstable injuries. We know that. We have just proven that again and again and again. Now multiple studies showing syndesmotic area is the thing that you need to measure. And now this proves that this weight-bearing CT scan is more valuable than, evidence is showing is that it's more valuable than a non-weight-bearing CT scan. And then they really confirmed this is the first study that confirmed that, hey, weight-bearing CT scan really does confirm syndesmotic instability on those patients as well. Highlights dynamic change when you're using weight-bearing CT scan. They, again, use contralateral image as an internal control, highlighting why you should get it on both. And insurance companies can't, if you give this literature, they can't really argue getting both. And then weight-bearing CT scan diagnostically diagnoses it better. And it's arthroscopy proven instability as well. And syndesmotic area shows the best diagnosis or most reliable for diagnosing injuries. I went through that really quickly, but I don't want this study to go super long. Just knowing syndesmotic injuries, weight-bearing CT scans rock. They really help me. Case number 5 through this presentation, left ankle injury. He's a 17-year-old male athlete, comes in, wants to be a really big football player. Has done some PT, done some things, but he had a bad injury, just not getting better. Felt a pop. Has not been the same since. He's worked with AT and physical therapy. MRI was done, and then they referred it after the MRI showed some damages. Basically, this whole area doesn't look good to me. I don't see a good ligament at the syndesmosis. The posterior looks right here looks okay, but the interosseous doesn't look normal in my opinion. I didn't like the way it looked. I don't see any major peroneal tendon issues. I wasn't super concerned about low ankle at the time. I was more concerned about physical exam, his high ankle, but he obviously had some pain at the AITFL as well and ATFL. So anterior lateral ankle pain, diagnosing it with the MRI helped. Also high and low ankle sprain what appeared. He's guarding in those areas. So I got right versus left x-rays for comparison. We already had the MRI, and then I got a weight-bearing CT scan. Based on those previous studies, why wouldn't you get comparison? It's the best way to evaluate internal controls. So left injury, something doesn't look right? This exam does not look right. The tibiofibular clear space looks like it's rotated or opened compared to his internal control of his right non-injured side. Weight-bearing CT scan really shows a significant difference. Abnormal, normal. So the left-hand side shows fibular rotation, shows how there is opening at that posterior joint and smaller space anteriorly, so the syndesmotic area is closed down on the left, and on the right side looks perfect. It looks exactly the way it should be, really showing that he had a significant injury. Likely he's getting subtle instability through his high and low ankle joints. So the surgery I performed was a scope. I did a syndesmosis ORIF, so I cleaned out the syndesmosis and I stabilized everything as much as possible. So I basically stabilized the interosseous ligament through tight ropes, but I also did a medial rostrum, so I did a deltoid repair to help close that ankle down, and then I did over top of that I did a AITFL repair. After I did medial rostrum, tight ropes, I also wanted to give a third point of fixation. And then after I did the high ankle, I stressed his low ankle, and he did have instability of his low ankle, so I did a lateral ankle, so I did 2 anchors and then an internal brace as well, giving him the most complex reconstruction that I can. Afterwards, this is what it looked like. So doing the 2 tight ropes, syndesmotic area looks much more normal compared to what it did preoperatively. I think it looks great, in my opinion. I think I did a good job. That's me tooting my own horn, but this is what I wanted to see, getting a weight-bearing CT scan after. He had some continued pain, mostly hardware around the distal fibula, the plate that I used. He wanted his peroneal tendons not to irritate, so I just wanted to make sure that I had good correction, that I didn't give him malunion or malalignment of a syndesmosis after surgery. So we got an x-ray. And more imaging. I use center when I fixate ankle fractures for syndesmotic. This shows you the center technique, fixating this, and what that would look like. I'm trying to get the insuria perfectly aligned. I'm trying to do center in the tibia and fibula to get that best insuria position, so less fibular rotation. And this paper really highlighted that. It's the center technique. We've done some research at my former institution as well, but this is showing what I believe what it's supposed to be looking like and highlighting. Takeaways from that: syndesmotic area is the most reliable tool to diagnose this. Again, I think of the insuria, I think of rotation, I think how it affects that anterior and posterior space, and I think about that rotation of the distal fibula. I love fixing any positive stress, isolated fibular fractures, or if it's even questionable because of that fibular rotation. I do not want fibular rotation. Even if it's subtle, it can still cause arthritis down the road, and I think these studies on these weight-bearing CT scans led me to be way more aggressive on just isolated fibular fractures, and I also am just really aggressive on fixing the syndesmosis on them. I usually just do a tightrope or 2 tight ropes because I do center, so I know I usually am going to be a good alignment. So I have low threshold on fixing isolated fibular fractures with a positive stress medial clear space widening. Or if I think there's any rotation on those x-rays versus right versus left, I'll also get a weight-bearing CT scan to prove that. I should have thrown this in this study, example of a 20-year-old, her foot, showing that we didn't fix an isolated fibular fracture based on her preference, but how basically a year after her injury, she already had lateral gutter impingement, lateral gutter arthritis, because we didn't fix it because of the fibular rotation. And it's really just eye-opening things once you read these studies on weight-bearing CT scans and these subtle syndesmotic injuries. Get contralateral imaging can aid in a diagnosis, especially x-rays initially, and then get them on weight-bearing CT scans. If you have any questions, I would recommend this highly, finding a weight-bearing CT scan in your region to really help you in your sports med practice. Implications for surgery. What do I mean? That I fix a lot of subtle injuries. I fix a lot of AITFLs with the internal brace. I also do tight ropes and deltoid medial rostrum type procedures. There's some good evidence for that. I kind of talked about the medial rostrum and a deltoid talk early. I'm probably going to do a high syndesmosis talk here shortly, where I talk about all about the syndesmosis to really highlight these studies and kind of go hand in hand with each other. together. I think if you're fixing the syndesmosis or fixing ankle fractures, there's things that you can look for. This is a paper out of Injury. I kind of talk about this on my deltoid talk, but you want to have the mortise be clear from this, all the lateral. You want to have a Mercedes-Benz side at the syndesmosis, and then you want to have the dime sign that we know about. If you get those three things correct intraoperatively on your fluoroscopy, you're likely going to have good reduction. There's a good reliable method for also further evaluation is if you're looking at the lateral image and where your fibula is positioned. It should not be too posterior or it should not be too anterior. If it is on that lateral image, you're likely malreduced. And this is a good example of, hey, they fixated it. And if you look at the center one, which is the control, it's exactly where it should be based on that preoperative and postoperative imaging. So there is some ways intraoperatively that you can access it, so you don't have to get postoperatively, get a CT scan afterwards. So just know that there's some intraoperative ways to do that. And then lastly, I think as being a deformity corrective specialist, I do a lot of hindfoot and complex deformities for my former orthopedic partners. I also do some total ankle replacements. I was the first person to do a total talus in North Dakota. I was also maybe the first person to do a custom sphere implant in North Dakota. So I have experience in doing these deformity corrections. And again, not tooting my own horn because there's lots of people around the area that now do this stuff. But weight-bearing CT scans gives you lots of information. What I mean by that, it's patient-specific, like we talked about. You're going to get knee to ankle, at least in our institution. We can get knee to ankle, we get ankle to foot, and then we get hindfoot to forefoot, like we've previously talked about the deformity. And total ankle replacements, this Dodd EDL review basically said CT scans are the way to go if you're going to evaluate it for deformity and evaluating the deformity, so you know where to correct the deformity. If it's intramalleolar or inferior malleolar, so if you need a calcaneal osteotomy, you need to do a flatfoot procedure. And they said, hey, you probably, if you can do a weight-bearing CT scan, you should. If you can't, get a regular CT scan at least to evaluate it. We're all probably, if we're doing total ankle replacements, getting CT scans, but if you're getting weight bearing one, you can really get that information that I previously talked about, that medial column, that foot and ankle offset number, and really help you dial in your correction. Whether you need patient-specific information versus standard information, there's multiple studies showing that, hey, standard implant information is relatively accurate. Patient-specific designs are maybe a little bit more accurate, but both work well. And I think this kind of proves that maybe we need to get a weight-bearing CT scan and then compare it to a non-weight-bearing CT scan and see if our implants are even more accurate than the ones that were previously studied. So I think that would be a good study. I'll kind of highlight that later on. But what I find is the most important is that patient-specific instrumentation is accurate, so you can trust it. And then second of all is if we can get a weight-bearing CT scan, can we help get better outcomes? So there's a couple studies recently as the role of rotation in total ankle replacement. So the talus is a 3D motion. It does a lot of 3D motion. So if there's some rotation of the talus that we don't pick up on, and the weight-bearing CT scan sees it better than a non-weight-bearing CT scan, maybe we can be more accurate of how we're placing our instrumentation intraoperatively, or know that. And I think this study, the role of rotation in a total ankle, is a good paper to look for. And then also the sagittal plane. So if we're too dorsiflexing our ankles to cut the talus, and we're not really paying attention to our parallelism, in my opinion, of our talus, if we're doing flat cuts and not the chamfered cuts, there is maybe patient-specific designs will help us get better outcomes. Now, I can't prove that. I don't want to say that because there's no studies on that, but that's my theory, that weight-bearing CT scans would be better. And then other indications, again, weight-bearing CT scans gives you that joint alignment that we just talked about, surrounding arthritis, deformity. I use it all the time. I do a lot of staged total ankles, so I'm usually going to fuse the subtalar joint if there's any subfibular impingement, if there's any impingement type issues or any arthritis. I'm doing a staged subtalar joint fusion, and then I'll go back and do the total ankle, or I'll do my deformity correction and then go do the total ankle. So I use weight-bearing CT scans a lot. And then there's, hey, if you're going to do a total talus, why wouldn't you want the most accurate information? So there's some good studies out there showing that basically you get better information if you're doing weight-bearing CT scans and getting more accurate information that way. Now, I'm not going to highlight all these studies. This is a lot of information to go out there, but it led me to this point, which I think is my last point, is that we need a study comparing non-weight-bearing CT scans versus weight-bearing CT scans and the accuracy of our implants, whether it be total ankles, whether it be custom implants, whether it be spheres. I think we need to do that and really study another way of studying it. And then again, all about accuracy. And then lastly, I'll just kind of go you what I use weight-bearing CT scans for is 3D printed models. So this is a deformity on a pediatric deformity. You can see that severe subluxation of the talonavicular joint. You can get a good view of that, and you can see his metatarsus adductus adducting his foot, and then you can still see he's got a hindfoot varus. So this again gives you that, hey, I can take a weight-bearing CT scan, I can print the model and have it in my hands and really get a good view of the deformity. I use it all the time in Charcot deformities. I didn't put those deformity pictures in there, but a really, really nice way to look at Charcot deformity as well. It really helps me determine if, hey, I'm going to do a midfoot osteotomy where I'm going to make my cut at, and then do a TTC nail. So that flipper foot really helps me get better information that way as well. And this is just an example of me doing a total ankle, total talus replacement. Had my orthopedic partner refer this patient to me after a bad injury. I think she had a tree fall on her leg at her leg place. Ended up crushing her talus, crushing her leg. He removed the rod, removed the hardware for me. I ultimately then did a total ankle, total talus replacement at one stage, and she has done well. She's now 2 years out. This is the first lady that was the first total talus replacement in North Dakota, and has done really well. Very happy about this. I was also the first person to do a sphere in North Dakota. This patient had a total ankle replacement done by my partner. Ultimately, she ended up failing that. And then she had a fusion done where they used femoral head. Ultimately, I think during the time of healing, she started walking on it too much. She ultimately went in this valgus position. I ultimately got weight-bearing CT scans on the total talus and this custom sphere, but we ultimately did a custom sphere for her, and she's done well with doing the custom sphere down the way. This is before Arthrex had their TTC nail, their compression nail, but ultimately restored 3D, and the Dyna nail really dialed this one in for me. But you can get great correction, you get great information by using these products, using weight-bearing CT scans to help you really maximize that patient-specific information that helps you make better plans going forward. And that's really what I have today. I hope you guys all enjoyed the weight-bearing CT scan talk and why maybe you can bring this to your practice. All right, guys, let's conclude this talk. I do believe weight-bearing CT scan is the new standard for advanced imaging. I think if you can find one in your area, you can get your clinic to buy one, you can get your practice to buy one. I would highly recommend it. I can give you financials through an email that would give you detailed information on what it costs, how much CT scans you're going to use to get this thing to pay off or be profitable for you. It doesn't take up a lot of space, and it gives you so many ways to evaluate deformities. Insurances usually don't push back on it. Overall, you get patient-specific information. You get subtle clues about deformity, arthritic changes, and injuries, as we previously discussed. My surgical implications, where we kind of talked about that it changes my procedures, and evidence shows that it can change about 30 to 40% of your surgical procedures you chose. Basically, I get a weight-bearing CT scan on most every patient that has a bunion, most every patient that has a flat foot or deformity, and here are the kind of ones that I consistently use it on. Most consistently for flat foot. I also use it obviously for a cavus foot, those type of deformities. Prevent recurrence of hindfoot pronation through first ray. I want prevent elevatus through first ray. So if I can evaluate those things, can I really help affect my flat foot reconstruction solutions down the road by knowing that they're where the collapse is at, how much it's elevating, the subtalar joint position, all those things that we previously talked about. And then the second and third things are bunions. So we really talked about my paper, and I'm just highlighting it because of the subluxation of the sesamoids. Kind of found that it's an independent factor of pronation, and then that it's present about 80% of the time based on those two papers that I presented. And then from our standpoint is that there's arthritic changes there 50% of the time, or roughly 50% of the time. And then the crista, is it absent or not absent? About 50% of the time as well. And then also most commonly used in my practice for syndesmotic injuries, the distal ankle injuries, so fibular fracture, and we're looking for syndesmotic area or that fibular rotation in comparison to that normal side, and I showed evidence for that as well. And then for me as well is most commonly used for deformity correction of hindfoot and ankle pathology, so total ankle replacement, 3D printed models for Charcot, those 3D custom cages, all those applications that we obviously previously talked about. All right, guys, if you have any questions, please reach out, mcclisterdpm@gmail.com. Follow me on Instagram to find out new presentations that I'm doing, see new cases that I might be presenting on, or any other information. But please reach out, add me, whatever you like to do. Drop a follow, as the Arizona sports guy I like to follow on Instagram says a lot. And then lastly, I am an Arthrex consultant. I do believe in their products, but there's lots of other good products out there and different hardware that you can use. But I clearly think Arthrex is one of the top lines producing for foot and ankle technology. All right, guys, have a great day.